Today on Diabetes Connections Type 2, a close-up look at hospital care when you have diabetes from the people who grade the hospitals. 30% of patients admitted for acute care have diabetes, but many hospitals aren't prepared or have staff properly trained. My guests from the watchdog group Leapfrog and from the American Diabetes Association will talk about what's being done right and how you can be better prepared if you need hospital care. This podcast is not intended as medical advice. If you have those kinds of questions, please contact your healthcare provider. Hello and welcome to another episode of Diabetes Connections Type 2. I'm your host, Stacey Sims. I'm really glad you're here. Important issue this week that unfortunately a lot of us are going to have to face and will have to use. If you've ever had to stay in the hospital, you know it's not the best place sometimes for somebody with diabetes. I mean, the food alone is a good example of this in a lot of hospitals. Sugar-free Jell-O, maybe, but also like a giant roll with orange juice will come for breakfast. To say nothing of the giant lancers they can use to check blood glucose. I remember years ago, a friend of ours was in the hospital. He didn't have diabetes. He had a condition where they needed to check his blood sugar at least once a day. And my son has type 1, so Benny was teeny tiny at the time, maybe 3 years old. And my friend called me. He's like, I don't know how your son does this. I don't know, these giant lancers and these needles they're poking me with. And a lot of hospitals use a very low gauge lancer needle. You know, if you're not familiar, the higher the gauge, the thinner the needle. I know a lot of people don't use blood meters anymore, but we used one for many years. And you can see on the package, you know, if it says like 33, that's a high gauge and a very fine needle. But the lower it gets, the more painful that needle can be. Some people need a lower gauge. I get it. But my friend did not. So we snuck him in one of my toddler's blood sugar lancers, and he used that with the teeny needles that we gave him, and he was much more comfortable. But, you know, a lot of hospitals are using higher gauge needles, and they're also letting patients keep their CGMs on. We're going to hear more about that today. It is starting to change. So this week, we're talking about what's going right with hospital care and what we as patients really need to know. At the start of every episode, I like to give just a little bit of information or define a diabetes term. And in the interview this week, we talk about the American Diabetes Association standards of care in diabetes. And I thought this would be a good chance to define that and just kind of say, like, well, what does it mean to us as patients? Every year, the American Diabetes Association Professional Practice Committee puts out standards of care. They update this annually. I'm going to link up the full list to them for the most recent year, and also a link where you can make comments. Readers are allowed or welcomed to make comments on the standards of care. So what are they? They are the current clinical practice recommendations from the ADA, and they're intended to provide healthcare providers and policymakers with the components of diabetes care, treatment goals, and tools to evaluate quality of care. This might sound like a big, dry report, and most of us are not going to go through and read it. But I can tell you, it's really important, not just for how doctors treat diabetes, but how insurance companies look at these things, and how, as you'll hear, how hospitals look at issues. They have been updating this annually since 1989. So it's really an interesting document that shows how diabetes care has changed over the last 25 years. And you'll hear a little bit about how those standards of care have changed when it comes to hospital systems. I'm going to link up the hospital section of standards of care. I will link up to the full document. It's a lot. But I'm also going to link up where you can comment. Readers who wish to comment on standards of care are invited to do so. There is a link. I will put that in the show notes. My guests this week are Leah Binder. She is the president and CEO of the Leapfrog Group, and Dr. Robert Gabbay, Chief Science and Medical Officer of the American Diabetes Association. The Leapfrog Group is a watchdog organization focused on healthcare and safety in hospitals. They've got their list for the recognized leaders in caring for people living with diabetes. This is the first ever national recognition program that aims to hold hospitals accountable for providing high-quality care for people with diabetes. And of course, the American Diabetes Association has the mission to prevent and cure diabetes and to improve the lives of all people affected by diabetes. Our conversation right after this. When you get a diabetes diagnosis, you have a lot to think about and keep track of. Your supply company should help lighten your load, not add to it. That's why I'm so happy to talk about US Med, They hold an A+ rating with the Better Business Bureau, so you know they excel in customer satisfaction. US Med always ensures you have 90 days worth of supplies and provides fast, free shipping to your doorstep. It's great to know you don't have to constantly run to the pharmacy or think about ordering every week. US Med, your trusted partner in diabetes care. Your health, satisfaction, and peace of mind are their priority. Better service, better care. Learn more, go to usmed.com/Stacy. That's usmed.com/STACEY. Leah Binder and Dr. Bob Gabbay, thank you so much for joining me. I'm excited to learn more about this. Thanks for jumping on and spending some time with me and my listeners.
Great to be here.
Yes, very much so.
Let's just jump right in and start talking about this program. What is this Recognized Leaders in Caring for People Living with Diabetes program? Kind of give us the high-level explanation.
Well, Leapfrog and the American Diabetes Association are recognizing 17 hospitals in 2024 for being leaders in the way that they treat their inpatients who are living with diabetes. So it's all inpatients. Lots of reasons people go to a hospital. This program is recognizing hospitals that pay special attention to people living with diabetes to keep them safe, because there's a lot of problems that can happen in a hospital, sadly. There's a lot of errors and mistakes and just infections, things like that. And those things can actually be more harmful or can put people living with diabetes more at risk. And so we want to know, do hospitals take the right steps to protect these patients? And are they doing a really great job of it? And those are the ones that we want to recognize together.
Great. Let's talk about the criteria maybe a little bit. Dr. Gabbay, what can a hospital do? I mean, I think we all think, right? We all have in our heads now something that we've thought of in terms of, all right, when I go to the hospital, this is the care I expect. But what are the criteria that you would look for?
Well, there are a lot of things that need to be thought about when a person with diabetes enters a hospital. The easiest one to imagine is their blood glucose levels. And there are a lot of things that happen in the hospital that make those levels really fluctuate a lot. People might be eating or not eating during the course of their hospitalization, infection, stress. All of those things can affect blood glucose. And what we know is that in general, people with diabetes go into the hospital tend to do much worse than people without diabetes. And so what we want to find a way is, how can we prevent those bad outcomes from happening? The program recognizes hospitals for taking a variety of measures that we know are effective. And so a simple example might be, if you're on insulin and taking insulin, that your food and the insulin arrive around the same time. Now, you would think that that's, well, of course, but food in a hospital is run by one group of people. Administering insulin is a different group, and they may or may not line up. And we see this, unfortunately, fairly commonly, that somebody might get their insulin and then are waiting for their food, and then they're at risk for, the blood glucose is dropping dangerously low. That's just one example, but there are a whole series of measures that we can talk about.
Leah, let me give it to you to kind of ask the same question with those measures. That's a great one with just insulin timing. But hospitals are so complex. Could you talk a little bit about what you look for in these awards?
Well, let me back up and say what we look for in general. We rate hospitals on how safe they are for their patients in general. We look for what I would call the shortfalls of that complexity. So, you mentioned, yes, hospitals are really complex, and it's difficult sometimes for them to manage to keep their patients from accidents and mistakes that can actually really hurt them or even kill them. So things like, getting the wrong dose on a medication, or not watching a patient who's at risk for falling and they fall, and that can be catastrophic to many patients. So there's a whole long list that would keep you all up at night, we'll put it that way. If you thought about all the ways that hospitals can make errors that can harm people. But some hospitals are better than others at really paying very close attention to all the ways that mistakes can harm patients. And that's why we give them ratings, and we look at that issue, and we publicly report on how each hospital individually is doing on this. So what this program does is it says something, it's another layer of protection. It says 30% of inpatients are people living with diabetes, which frankly was an astronomical number that I was shocked to hear myself. I learned a lot from Dr. Gabbay and and all the team at ADA. And that was the first thing I learned that shocked me, was how many inpatients are people living with diabetes, and they don't check their diabetes at the door when they're admitted and say, oh, now I'm in for something different, so I'll leave the diabetes for later. That's not how it goes, right? They're in the hospital, and the same errors and accidents can hurt them, but suddenly there's a whole new level of errors and accidents that can also hurt them. So as Dr. Gabbay points out, the wrong timing of medication and diet, and not getting an A1C test in the right time, in the right time frame, et cetera. There's a long list of special concerns that these patients have when they're in the hospital, regardless of why they're in the hospital. They have a certain level of concern. So their risk as a patient in general, it's pretty high because we have a problem with patient safety in our country. And then they have this added risk. So the question is, how do we find those hospitals that do an exceptionally good job at both patient safety and for all patients and for their patients living with diabetes? And that's what this was about.
And Dr. Gabbay, I'll put this to you. Knock on wood, my son who lives with type 1 had been hospitalized only once for something that we thought was diabetes related. And it kind of was. It was really more dehydration, which obviously can be related. It was a high blood sugar thing, but he wasn't in DKA, didn't have high ketones. But when I went to the hospital with him, the emergency room doctor said to me, I'm going to manage this part of the situation. You manage the diabetes. And I was really thankful for that. I mean, I'm a caregiver. I'm a mom. This was an adult by himself, but not everybody can do that. And do these hospitals, and we can talk more about what patients can do a little bit later on. Do these hospitals excel in caring for the diabetes part of the equation, or do they excel in just not making it worse?
Well, Stacey, I think you hit the nail on the head. Really, they excel at providing care for people with diabetes. And a lot of that is, you mentioned the complexity that hospitals are. What really helps to deal with that complexity is when hospitals have protocols that are agreed upon ways, best practices to manage different situations. So as an example, when someone has a low blood glucose in the hospital and they need to be treated, well, if you don't have a protocol, Dr. X or Nurse Y might do one thing, and someone else might do something else, and a third group might do something differently. Having that protocol makes sure that everyone's on the same page, everyone's following what we know the evidence shows is the safest way to manage someone, and that the right thing is the thing that's done virtually every time. So protocols are so important. And one example I just described is around, dealing with low blood glucose and hypoglycemia. But similarly, what happens when somebody goes to surgery? Very common for people with diabetes. One of the big reasons people are hospitalized. What happens with their medications? Well, without a protocol, every provider has a different view potentially. And we know that doesn't work, right? There have been studies. We know what is most effective, what is safest, and it's ensuring that those kinds of things are implemented. And these hospitals that were recognized do those types of things very well.
And can I add something?
Please go right ahead.
Because your story troubled me mostly as a mom. I do not have a child living with diabetes, but I do have children with lots of other ailments and over time. And I can say that I am amazed at how much parents are expected to know and manage in their children's healthcare. I mean, you have to be sort of a pediatrician, ultimately, if you're going to be a successful parent, especially if a child with chronic disease. But you don't check it at the door. It is true. I mean, they actually really are. Your physician, unfortunately, was going to treating it that way. Like, well, we'll put that aside for a while. No, your child lives with both diabetes and the reason that they're in the hospital. I mean, both at the same time. And these are humans that have to be treated as one human, not as one disease or another disease at one time. That's not how it works. That's just not how it works. And so I do think that's an example of why it's so important that we recognize the hospitals who get it, who say, okay, we get it. We have patients living with diabetes. We've got to do all of it. We've got to take care of them in all ways.
I agree with you 100%. Again, I think my story illustrates in my relief that he was going to let me do that part that we as a public perhaps don't trust, right? Because because we haven't seen that sometimes. We've heard the bad stories. We don't hear enough of the good stories. I do remember hearing a couple of years ago about continuous glucose monitoring in hospitals. Dexcom was part of this. Perhaps other companies have since joined. Is there an update on that? Do any of these hospitals really integrate CGM into treating their patients with diabetes?
I can speak a little bit to that. So, one of the things that happened during the emergency measures around the pandemic was a waiver to allow continuous glucose monitors to be used in the hospital. And that's something that the American Diabetes Association really supported and was pleased to see that happen. There were a variety of reasons you could imagine that this became necessary. The risks of exposure of healthcare workers to COVID-19, et cetera. That started to allow collecting information on whether continuous glucose monitors are accurate and safe and effective in the hospital. They've not been approved yet by the FDA, although that may happen soon because there are a number of studies that are looking at that. That said, our American Diabetes Association standards of care that really define what care should be based on the evidence. In this year's edition, there's a lot of information about the use of continuous glucose monitors in the hospital. And whereas they shouldn't be used to adjust medication like insulin because they're not approved for that purpose, they can still provide really useful information for people living with diabetes that are in the hospital, as well as the clinicians that are caring for them.
I didn't realize it wasn't approved, that it was still like a COVID waiver. That's interesting.
Yes, and it's being reviewed by the FDA, so stay tuned.
Stay tuned. Definitely. All right, Leah, tell us a little bit more about the hospitals on this list. And you don't have to go through them all. We can link it up. But we had mentioned like talking and sharing about some of the good stuff. Can you give me examples of what they're doing right? It can be pretty tricky to travel with insulin, especially if you're going somewhere very cold or somewhere very hot. We have found something that really works well for us, and that is the ViviCap from Tempramed. It keeps your insulin at the exact right temperature, even in the extreme heat or cold, and it works for any insulin pen. Super simple. You just take the cap off your insulin pen and you slide the ViviCap on. No batteries, no charging, no water or ice packs. It lasts for years and gives you 24/7, 365 protection because insulin is very temperature sensitive. ViviCap has a 30-day, 100% money-back guarantee, and it's got a 2-year warranty. Find out more. I've got a link in the show notes for you, or you can go to diabetes-connections.com and click on the Tempramed ViviCap logo.
Well, they are implementing some really exciting programs. Like Geisinger has 4 hospitals on this list, and they're all in Pennsylvania. And they have done some really innovative programs, particularly around educating people so that when they're discharged, they know what next. Because when you're discharged from the hospital, you typically have new medications and you have sort of new instructions. So making sure that people really do understand those and they have the right supports in their own home to support that. They have immediate follow-up from the hospital to the home to try and observe and make sure that they do know that they have what they need. And that is a big problem for people living with diabetes. It's been a known hazard for their care is that they aren't always aware of all the things that they need to do. Like you are aware for your son, but sometimes people, they have a new level of a need in terms of their follow-up care because they're at a higher level of acuity. Anyway, so Geisinger, I think, has done a great job with education. We have some hospitals in New Jersey, 3 in New Jersey, 1 in New York, Glen Cove Hospital in New York, a nice community hospital. It's done some great work. I mean, I could go on. There's 17 of them, and they are truly remarkable in their ability to try to really live up to the standards that really ADA has set from the beginning of how we want people treated.
So, this situation of what happens when people are discharged from the hospital. So we know that not only people with diabetes have high blood glucose in the hospital, but many people without diabetes can have high glucose levels in the hospital, need to be managed appropriately. And some of those people may need to go home on insulin, as well as many people with type 2 diabetes that come into the hospital not on insulin, but to control their blood glucose when they leave, need insulin to be able to manage their diabetes. Particularly those you might imagine that, for example, had surgery and have a wound that has to heal. And we know that high blood glucoses interfere with the healing process of wounds. Making sure that people really understand, okay, you're going home on insulin. It sounds trivial, but let us teach you how to inject insulin at home because you weren't doing that before you came to the hospital. And we've been doing it while you're in the hospital. That's really important. And then who to report back to with the blood glucose numbers to say, okay, I need to adjust my insulin because one's activity and food out of the hospital is going to be very different than in the hospital.
Let's kind of flip it around from the patient perspective now. What's your advice? People don't generally have a choice of what hospital they go to, especially if it's an emergency situation. How can people with diabetes better prepare before there is a reason for them to go to the hospital? And then what can they do once they're there?
I'll start with a general advice that we give all patients. And to begin with, you want to try to have an advocate with you. To the extent you have a family member, a friend, loved one who can be there as often as possible, you're in much better shape. And that person should be not shy. Let's put it that way. That person should be willing to say, what is the medication that you're giving? Because you should check medications. It's the most common error made in hospitals is giving someone the wrong medication or the wrong dose. So you should just check. And then they should also, in the case of people living with diabetes, they even have to check more to get the timing of the insulin right, et cetera. And sometimes advocate to make sure that those meals get delivered on time, et cetera. And all of those steps are taken. So there's just some fundamentals. And it's very hard to do that when you're in a Johnny in your bed in the hospital and you're nervous and it's hard, very hard to advocate for yourself. So it's good to have someone there with you. But even if you are by yourself, there are things, again, you can do. Monitor your care and don't assume that because all of the physicians and nurses and others that are working around you they're so bright and they're so nice. I mean, all those things are true, but they also can get your care wrong because they might be distracted or other things happening. So it is really important for you to be not shy yourself about asking the right questions and kind of making sure you're getting what you're supposed to be getting. Don't assume that they must know better, ever. Don't ever assume that. You're the expert on you, always. And unfortunately or fortunately, whether you like it or not, that's the position you're in as a patient. You have to take charge of your own care.
I'll add to that and maybe really highlight this idea of advocating. It's not being afraid to ask, what am I getting? Why am I getting it? And they should be able to explain it. And honestly, it's the healthcare team's duty to do so. So you should feel empowered to ask those questions, particularly when it comes to one's diabetes, because again, you've been managing your diabetes all along. Now, I will say you also need to be listening to the answers because things are different in the hospital. What worked, to manage your diabetes out of the hospital may not be the same thing in the hospital because of illness and, all of the things that affect your blood glucose levels in the hospital. But advocating and where possible, having someone else do it because it's obviously very disorienting to be in the hospital. You're being woken up in the middle of the night most of the time, all of that. The other thing is, although often we don't have a choice of what hospital we go to, in emergency situations, we do often have a choice when it's an elective procedure. And that's where looking at hospitals that have been recognized could be very helpful.
Have either of you been in hospital lately? I'll just share. I had a really serious situation about a little bit more than 10 years ago. And I'm super grateful for the care. I wound up firing one of the doctors while I was there because he was frankly very patronizing and insulting to me. I have no idea about his medical care, but he had a great partner. And so that's why I worked with. But I have to tell you, it really had to get to the point where it was very difficult for me because no one wants to be the bad patient. No one wants to be the complainer, right? Nobody wants to ask too many questions. So I'm curious if you either have been in that situation and how you might have dealt with it.
I have definitely been in that situation. So my organization grades hospitals in general on how safe they are, A, B, C, D, and F. So the D's and the F's sometimes are sensitive about that, though they get better. They always get better. But anyway, so last year I was there with a loved one and it's sensitive and people don't like sometimes to hear a lot of questioning of what they're doing. And I was not at a hospital that I normally would have been at. I wasn't a voluntary situation. So, it was an emergency situation. And so sometimes I felt like I had to be exceptionally pushy. And a lot of people in healthcare actually know this. We know who to call to find out who's who in the hospital. And, it's just unfortunately not every patient knows that or can do that. But people in healthcare do know to do that. That said, the only way that hospitals are going to learn the importance of what the patients have to say and their perspective on the care is if we speak up. We have to speak up. They're not going to get better. And we're not going to get the care that we need if we don't learn to speak up. And I will say this, some hospitals are much better than others at accepting that patient feedback and really valuing it. So you never know. You had one, sounds like bad experience. And sadly, that is not uncommon, but you have to push past it. Everybody has a philosophy on this, but my philosophy is that it is not a good idea to try to be so nice that you don't say anything, because hospitals are dangerous places and you really have to be on your toes. And you can't afford to be too nice if it comes down to that. Hopefully it doesn't. But if it does, you have to be assertive. It really is about life and death. You have to be assertive.
So I've been on both sides of this, providing care for people with diabetes in the hospital. And, I appreciate the sort of physician side of you're there, let's imagine a weekend, and you've got a long list of people to see, and you start early in the morning, and you're not going to go home until you've seen everybody. And so the quicker you do that in some ways while providing good care, the better, right? So you see the incentives that are there. On the other side, recently, I've stayed in the hospital with each of my parents and gotten to see things from the other side. And it's always humbling, particularly for a physician, to be on the receiving side of the healthcare system. It's so chaotic. People pop in, pop out, often not sure what their roles are, which one's a nurse, which one's a doctor, what are they here for? Again, I know the systems, so it's easier for me to identify. And the conversations are usually time sensitive, pressured conversations. It's not uncommon. A patient is woken up from a sound sleep to ask them about things, and they literally just woke up. I don't know about you. When I just wake up, I'm not really very, very clear headed until I've had my coffee and all that kind of stuff. So you can see all of those challenges. And I agree with Leah about being your advocate. I think what's also helpful is that most everybody's trying to do their best here, and there are a lot of pressures, and time is clearly one of them. I think advocating, but doing so respectfully, being kind is always helpful. Little things, boy, it must be a crazy day for you. Some empathetic words just sets up the relationship maybe in a little bit of a better way, because you want to try to avoid an adversarial sort of situation. Now, sometimes you've got someone you're dealing with, and that's the only way it's going to go. Most all hospitals have patient representatives that you can call upon when there is an issue. And sometimes you have to escalate, but starting nice and then escalating as needed.
Yeah, I think what we're trying to do too is empower people to just be able to say, hey, that's not how I normally manage my diabetes. I normally take less insulin than that, or I'm confused why you would want to monitor me this way. I check my blood sugar, 4 times a day at home. Why do you want to do it 10 times a day or whatever it is? Just even asking from that point of view, I think can really open up a conversation. So, right, hopefully we're not starting from an adversarial position, but it can be kind of scary for folks. I totally get that. What is next for the list? Is this an annual event? Do you look at hospitals and grade them every year?
That's the goal. There will be applications open in July for hospitals that are interested in applying for the designation for 2025, but they have lots of time, because they have lots of time all through the fall to get themselves in place, make sure they're in line with the guidelines throughout their organization. So hopefully we'll have even more than 17 in 2025. And I think if any of your listeners know someone at a hospital or a board member, it doesn't hurt to say, this really matters to me. I'd like to see my hospital try for this designation. They might not get it in the first year, but they can try for it. And just trying for it can make a big difference.
And what we're really excited to see is this was really the first time, and it's a first of a kind approach. We want to see more and more hospitals step up to do this. We're sure that they're out there. And at the same time, having them just look at the measures and know what should be expected They may not be ready to apply right away, but form a group in your hospital and start thinking about how can we implement ABC. Because what is really gratifying about the program is that it was an exhaustive process of a group of experts in the field that really went through the literature, looked at all the evidence, debated, discussed, including people living with diabetes as part of the committee to come up with here's the best way to deliver care for people with diabetes. So we were looking forward to seeing more and more hospitals step up to do this.
Great. Before I let you go, though, I just want to revisit one thing. 30% of people in the hospital having inpatient procedures having diabetes. That's a number that really makes you pause. And so I'm wondering, is the ADA, was that new knowledge for you? Is that something that you kind of said, let's circle that and look at that and see what else we need to do as an organization?
Well, I think it's something that people don't realize so much. And I can tell you that having worked in my other roles before coming to the ADA, we would often ask hospitals like, what do you think the number is? And they would do some calculations, often not done effectively, and then be like, oh, I think it's like 10%. We'll be like, okay, well, here's how you can measure it. Now come back with your answer. And they're like, oh, yeah, wow, it's a lot, 30%. So I think even amongst clinicians, it is not well appreciated. And I think part of that is that often people with diabetes may come into the hospital and no one may be following their glucose levels.
Yeah.
And not even really thinking about diabetes as something they have. And that, as you could imagine, is really problematic. We do want people to realize that if you work in a hospital, you need to think about diabetes because it's about a third of your patients.
Leah Binder, Dr. Rob Gabbay, thank you so much for joining me. I hope you'll come back either next year and talk about the list again or on other hospital topics because it's very high interest. We really want to stay safe out there. So thank you both for joining me. I appreciate it.
Thanks for having me.
Thank you so much.
I'm going to link up the full Leapfrog list as well, so you can see if your hospital is there. There were a lot of local news stories done when this list came out, so you may have already seen if your town's hospitals are included. And I will link up more about the standards of care and other things we talked about. You can always go to diabetes-connections.com and click on the Type 2 show. If you like what you've been hearing on this podcast, do me a favor, go into whatever podcast player you're using to listen and rate or review. I really appreciate that. And when people say that, if you don't know, rate just means like give it hopefully 5 stars, but that's the star review. You just click it and move on. The review is where you actually write something. Either one's great, whatever is easy for you. And just share the show with someone you think might benefit from it. Thanks to my editor, John Buchanan from Audio Editing Solutions. Thank you so much for listening. I'm Stacey Sims. I'll see you back here soon. Until then, be kind to yourself.
Diabetes Connections is a production of Stacey Sims Media. All rights reserved, all wrongs avenged.